A short introduction about V.Maestrini. She is a cardiologist, a specialist in cardiac MRI, and she's now developing a program, a specific program of cardiac imaging with MRI in our institution. Viviana has a long background in imaging, also in London, and so tell us something about the proper indication interpretation of the MRI in athletes, please.
Good afternoon. So cardiovascular magnetic resonance has a lot of advantages. So first of all, it's safe. There is no radiation exposure, so you can do safely in the pediatric population, and you can do follow-up studies because there is no exposure. And also the contrast agent is very safe. There is a low proportion of, low incidence of collateral side effect from the contrast agent. It's considered the gold standard for volume and function quantification, and we will see later why. There is no acoustic window limitation, so you can do easily in everyone. The true added value is the possibility to tissue characterize the myocardium, and we will see later how to do it, and potentially as a clinical indication in all the cardiovascular diseases. As you can see here, you have a lot of sequence that you can use and combine to create your protocol to answer to your clinical question. You can do volume, function, and mass. You can do perfusion after the administration of, for example, adenosine. You can do tissue characterization. You can study viability. You can study metabolisms. You can see very well the morphology and the function of the valve. You can study the great vessel, and you can study coronary arteries origins. I would like to specify here that CMR currently is really good for the origins. It's not really good for see stenosis, for example. In this case, CT is the gold standard. But if you have a young guy and you want just to check the origin of the coronary arteries, you can do a CMR, 5 minutes. The added value is principal in the setting of the cardiomyopathies because you know that there are a lot of changes in the heart, in the athletic heart, that can mimic some forms of cardiomyopathies. And in the gray zone, it's very difficult sometimes to distinguish between the two phenotypes. So first point, morphology. As you can see here, CMR is giving you amazing picture, very clear. And the border between the myocardium and the blood is really clear. And you can measure segments, you can see regional wall motion abnormalities in the left ventricle and in the right ventricle. On the top, you can see a four-chamber view. On the bottom, you can see a short axis stack that is perpendicular to the four-chamber view. And you can see here, there is... It's working, this one?
Yeah.
Oops.
Rosso.
Okay. You can see here the left ventricle and the right ventricle from the base through the apex. And here you can see two patients, two on the top and the other one on the bottom, with an echo and the CMR. It's the same patient. Here you can see an overt cardiomyopathy, an apical cardiomyopathy. In this case, the CMR is not giving you really an added value because you can easily see the hypertrophy in the echocardiography. In this case, you can do CMR to see if there is any late gadolinium enhancement. But if you look at the next slide, you can see that there are some area and some cases in which can be useful because the tiny amount of hypertrophy or other abnormalities, like this picture here, where there is a diverticulum here, can be easily missed by echocardiography. Fernando told you that in the athletics setting, we used to work with guys with a very good acoustic window, but it's not always true because sometimes you can have, for example, a pectus or other like deformation or any other problem. So if you have any doubt, you can do a CMR and sort out the problem, or as in this case, highlight the fact that there is a tiny bit of hypertrophy in the apex in these two athletes here. And this hypertrophy is not diagnostic, it's not reaching current criteria, but it's telling you that there is something wrong. This is not a normal aspect for an athlete. In the normal subject, in controls, in sedentary controls, but also in all the athletes, we should see a gradient between the base to the apex. So you should see the base more thickened than the apex, or at least the same, okay, thickness. When you have the other way around, so the apex is more thickened than the base, so the ratio is in the other way around, is abnormal. And below, you can see another area where you can easily miss the hypertrophy, that is the anterior anterolateral wall and the interventricular septum at the RV junction. Here, one case, recently, we saw this guy recently. So here this is the echocardiogram at the RV insertion point showing 12 millimeters, and here is the CMR showing 16 millimeters. Why we want to do this? Because when I was in London, we did this study because we used to see we saw some cases like this one, okay? No overt cardiomyopathies, but the gradient, there was no normal gradient. The apex was tiny bit more hypertrophied than the base. And few years later, this patient came back and have an overt cardiomyopathy. And because we are working with athletes and we want to prevent sudden cardiac death, we want to essentially diagnose the disease before, or at least in an early stage of phenotype, we want to find this group here. We would like to avoid to arrive at this stage. So this study was performed, and we found a setting of people presenting with T-wave inversion that actually have a relative apical outcome. And look at this case. This was one of the recent cases. Is 14 pro players, sorry. And this was the scan. On the top, you can see the 2015 scan, and this is the recent scan. As you can see here, we move from 10 millimeters here to 30 millimeters here, but much more important, you can see that here there is hypertrophy with a normal cavity size. That is something that we consider abnormal, because it's in a polo player with expecting a tiny bit of hypertrophy, but a dilatation, a concomitant dilatation of the chamber. In this case, was completely abnormal. Another thing is find minor abnormalities. Again, because we would like to detect, we would like to do the diagnosis in an early stage, we are also looking for other minor abnormalities that are known to be potentially associated with a genetic mutation to have more details. And these minor abnormalities are the possibility to have an elongated mitral leaflets, the presence of crypt of cleft, and I would like to discuss a little bit more with you probably in the discussion. The presence of papillary muscle abnormalities that are quite common in the sarcomeric mutation, but not only in the sarcomeric mutation, an apical basal muscle bundle, and an increased trabeculation. Increased trabeculation is another problem in the setting of sports cardiologies, because we know that an overload, like in pregnancy or like in athletes, can increase hypertrophy, and it can be seen in the normal range, but sometimes can be very marked, and especially there are a lot of difference between ethnic groups, so we need to consider the trabeculation in the spectrum of the athletic heart, but there is some cutoff. And then you can also see the RV involvement, and you can see very well with cardiovascular magnetic resonance the right ventricle. Indeed, the right ventricle is very difficult to analyze by echo as a complex geometry. If you see the right ventricle on the axial plane, you can see that there's a crescentic shape, while the left ventricle is much more easy because it has an elliptic shape, and also has a very complex anatomy relative to the left ventricle. And if you think how we analyze the right ventricle by echocardiography every day, it's quite poor. Yes, we can see by a subcostal view, we can do some offline wind view, but in everyday practice, especially if you work in a hospital, if you don't have a lot of time to analyze a picture, you use to assess the right ventricle based on your fourth chamber But this is wrong, because you are doing an assumption. And the assumption is that all the RV segments are working well, as all the other part of the ventricle, but this is not true, because you are looking just at 4 chamber. By CMR, you can do something more, and you can do easily, because as you can see in this picture here, you can obtain this picture just from a 4-chamber view and the short axis. The yellow line are the line that we use to pilot the acquisition. So you put here, following the long axis of the right ventricle, through the pulmonary artery, and we can obtain this picture here, when you can see the inlet, so the tricuspid valve, the apex, and the outlet, so the pulmonary artery. And you can see the dysplasia triangle. But you can do something more. So you can obtain, let me see this. Okay. You can obtain an RVOT picture, and piloting the picture perpendicular to this one, you can obtain the axial stalk. This was done to study the right ventricle, because as you can see here, the right ventricle, this is the free wall. You can analyze all the segment from the top to the apex and see if there is any regional wall motion abnormalities. And this is really important, again, in the athletes, because if you think about the criteria for example, the arrhythmogenic cardiomyopathy, in the minor and the major and minor reporting a dilatation of the right ventricle. But if you work with athletes, you know really well that almost your athletes are far above the cutoff. So you cannot use that cutoff to diagnose your dysplasia in your athletes. So having a tool that allows to study really well if there is any regional wall motion abnormalities is really important. And this is an example. This is a 12-year-old football player. He came to the doctor to have his certification because he wanted to start competitive sports, and he do obviously ECG first, he had an echo, and this is an MRI. And I put this picture here because this is showing you how it looks like a regional wall motion abnormalities in the right ventricle. And this was the original ECG, and he has a plakoglobin mutation. And also you can study valve. Here you have some example of the aortic valve and the great vessel. And you need to remind this, because if you have a young guy and you are not sure about your echo window, you can avoid to do a TOE. You can do a CMR, 5 minutes again to see the valve. And if you add contrast, you can have this beautiful aortogram, and you can study all the segments and all the measurements that you want to do with no radiation. Second point, CMR is really good to study volume and function, and currently is considered the gold standard. Why? Because you can create your volumes, your 3D volumes, starting from your short axis. And as you can see in this picture, the border between the blood and the myocardium, but also between the myocardium and the pericardium is really clear. So there is no doubt, no assumption, okay? You draw your region of interest, your epicardial border, all around the myocardium, and it's very precise, and it's very robust. And there are several tools that you can use to analyze your data, can be manual, semi-automatic, but all of them are giving you a very robust and reproducible data, and you can also have this 3D reconstruction. The problem is that we need to define what is a normal and what is abnormal. And clinical entity of the athletic heart has been defined with increasing precision over the last decades with different techniques. But we know that echo and CMR are not interchangeable and are providing you different number. So you should be not surprised if you have different number between echo and CMR, because echo is systematically showing you smaller atrial and ventricle dimension and volume, while it's giving you larger wall thickness and mass. This is normal. The only thing is that they should go in the same direction, obviously. Otherwise, if there is a discordance, there is something wrong. And we should also consider the sports activity. This is another important aspect. When I analyze the picture, I used to ask to the athletes, which is your sports, which is the number of hours of training, the intensity of the training, because I'm not expecting the same changes in different sports categories. Here you can see in this study, that they analyze the ratio between the mass and the volume. So here we are not talking about ratio between thickness and the diameter, but we are talking about mass and volume. And you can see that all the sports category based on the static and dynamic component align on the same line, okay? While the aerodynamic and diastatic has much more mass than the volume. But there is another important concept that can help us to distinguish between athletic heart and cardiomyopathy, that is the balance of the dilatation. When you have a left ventricle that is dilated, in the athletic heart you should expect a right ventricle that is dilated. The ratio should be around 1. If there is the left ventricle more dilated than the right, there is something wrong, and the other way around. But the true added value compared to every other imaging modalities is the possibility to tissue characterize the myocardium. The meaning is that you give contrast to the patient, to the athletes or whatever. You have the contrast is extravascular and extracellular. The meaning is that it's leaving the blood, it's going between the cells, and if the membrane is intact, like here, the contrast is stay between the cells. But if the membrane is damaged, or if there is collagen, there is a lot of gut that's going inside the cell, so it's going between the fiber. If you give the gut, in the normal myocardium, the contrast is going in and is washing out at a certain rate. If you look at what's happening in the scar area, these late enhancement arriving late, stay longer, and there is much more gut. If you acquire the picture after 10 or 15 minutes, and this is why we call late or delayed enhancement, because we need to wait a certain time, you acquire the picture and you maximize the difference between the contrast that is in the normal, that actually is out, and the fibrosis, the scar. And you have the picture that everyone knows, while the black myocardium is normal, and white has the contrast in, and there is fibrosis, there is scar. And why is working so well? Because we know from a lot of validation study, that it's matching perfectly with histology. So this is an hypertrophic cardiomyopathy, it's an end-stage disease. This picture is coming from the study published in 2004 that is the histopathological basis of hypertrophic cardiomyopathy, and is showing that the late enhancement is matching perfectly the collagen colored by Picrosius red at the autoptic study, even in the papillary muscle. So it's working really well and has a diagnostic role. Why? Because the distribution of the late enhancement is giving you information on the underlying diagnosis. And if you have an ischemic pattern, your late enhancement is going to be subendocardial, and essentially is following two rules. The first one is the wavefront phenomenon. So it's starting in the subendocardium, and if there is no revascularization, it's becoming transmural, and is following the coronary distribution. This is a subendocardial, and this is transmural in the anterior, in the territory of the LAD. Indeed, the other one that should follow the coronary distribution. Then there is the biggest word of the non-ischemic pattern, and you can have a lot of different patterns. This one is a mid-wall, and it's very typical for a myocarditis. This one is an RV insertion point, and along with the asymmetrical hypertrophy is typical for an hypertrophic cardiomyopathy. This is, again, a little bit subepicardial here, but intramyocardial mainly, and it's very typical for a lamina mutation, so primary cardiomyopathy. This is a subendocardial, and again, it's very typical. Localization here is basal in the lateral wall at the base segment, and it's very typical for a myocarditis. And this is a pathognomonic picture for an amyloidosis. And I would like to explain you the importance of the late enhancement showing in this picture. Here you have 4 phenotypes of hypertrophy, and I would like to ask you if you are able to tell me which is the underlying diagnosis based on this picture. Obviously the answer is no. You can add your clinical information, your ECG, your biomarker, and for sure you will have more details. But the first one is an hypertrophic cardiomyopathy, then there is an hypertension, a cardiac amyloid, and a mucopolysaccharidosis. If you do the same with CMR, you have this spectrum here of phenotype, so you can judge your morphology, but if you add the tissue characterization, you have more information and you're able to tell which is the underlying diagnosis. This is a prognostic role. I'm going to show you this study from the Padua group, from Dr. Zorzi. And this is a study done of athletes presented with ventricular tachycardia, and they found a proportion of them that had this non-ischemic, because it's mainly subendocardial, late enhancement, and this was associated with arrhythmias and sudden cardiac death. And this scar is not seen, echo is not able to see this scar. And another thing that they found is that sometimes there is this tiny bit of late enhancement that CMR people call minor enhancement. We call minor because now we know that it's not associated with clinical arrhythmias. And we did another study that currently is under review in London, and we found that 10% also of the normal subject have this tiny bit of RV insertion point. So if you found a report reporting that there is an RV insertion point and the geometry of the ventricle is completely normal, you can be reassured. And then we found another big proportion, almost 20%, that has papillary muscle. We don't know which is the clinical meaning of this. We need to find out, but it was quite common. And if you look at this picture, you have 3 examples of an RV insertion point. The first one is an ACM, the second one is an athlete, and the third one is a controls. But if you pay attention, you can see that in the first one, there is an asymmetrical hypertrophy, while in the other 2, the geometry is completely normal. So if you have a normal ECG, normal geometry, normal function, everything is normal, and the only thing that you can find is a minor RV insertion point, you can be reassured. Not only fibrosis, CMR is also able to see fat and to see edema. And you can combine all in the information to do a proper tissue characterization. So as you can see here, there is fat in the myocardium. This is a left dominant arrhythmogenic cardiomyopathy. This is the same picture where the signal of the fat is saturated, so it's not present. So we know for sure that there is fat. And here there is edema. This is a young guy presented with chest pain. You can see the late enhancement here, but you can see also the edema, the high signal intensity on the T2 weighted picture. You match these 2 information, and you can say that the guy has an acute myocarditis. There are some diagnostic challenges. It's not so easy, and the challenges are related to 3 principal problems. The first one is the problem of the normal variance. The second one are the mimicks, and the third one is how to read and how to interpret some findings in high pretest probability. So when you analyze a scan in a guy that has relatives with a gene-positive disease. So look at this picture, for example. If you look at the shape of the right ventricle, this was considered for a long time abnormal. And if you look here, you should probably be more worried because you say, oh, what's going on the right ventricle here where there is a moderator band? Now we know that these are normal variants, can be normal variants, okay? Can be found, we know because now we've done a lot of normal studies on controls, and we know that this can be completely normal. So sometimes this can create challenge, a problem. And these are the mimics. These are 4 cases presenting with T-wave inversion, V1 to V3. And as you can see here, there are some, the correspond MRI picture. And look at the diagnosis. The first one has a partial absence of the pericardium. When you don't have the pericardium, your heart is moving. There is a complete displacement through the left thorax. The second one here is a pectus. And when you have pectus, again, your heart is moving through the left hemithorax. And the right ventricle you see here, is towards the anterior wall. And here there is a rib cage abnormalities, and here you have breast implants, a pectum carinatum, and both of them created the ECG abnormalities because otherwise these people were completely normal. Limits. So late enhancement is working really well. It's validated as diagnostic significance, as a prognostic significance, but as limits. And the limits are that it's rely on a dichotomy. You can see just white and black picture, anything else. And late enhancement is always white. You can have a amyloid, you can have hypertrophic cardiomyopathy, you can have sarcoid, is always white. And it's missing diffuse processes. So late enhancement is working really well if you have ischemia, if you have an infarct or if you have amyloid, but it's not working really well when you have diffuse processes, like, for example, in an aortic stenosis. But now we have the T1 mapping, and the T1 mapping is promising to add a new dimension for the tissue characterization because it's able to detect these diffuse processes and is able to distinguish between cellular and extracellular component. And this as a tool has a whole the potential also in the athletes, and I will show you soon why. This is an electronic microscopy. This is a normal heart. This is the myocytes and the space between the myocytes. And here you have aortic valve stenosis. The myocytes are bigger, but there is also an increase in the extracellular space. With this technique, we are able to measure non-invasively the space between the cells and what is cellular and what is extracellular. And this study, published last year, published some preliminary data on the possibilities to apply the T1 mapping in the setting of the athletic group. Increasing the performance, you can see here the VO2, we know that the mass is increasing and the volume is increasing. But we know now that mass is increasing because it's an increase in the cellular component. The meaning is that in the athletic group, hypertrophy is a cellular hypertrophy rather than extracellular. And this is all the potential to be used in the setting of the gray zone between the athletic heart and cardiomyopathies. Here you can see that in ACM, in a hypertrophic group, the extracellular component is increasing. So if you have much more mass, this is extracellular space, while in the athletes, this is going down. And if you look in the gray zone, you can see that the T1 mapping is able to distinguish between this entity. Down. This was preliminary study. If you look, the numbers are very small, so we cannot see that this T1 mapping is magic, and we probably sort out all our problem, but it can be a useful tool and can be integrated in the practice. Another future perspective of the CMR is the possibility to do an exercise CMR. Now we do have compatible ergometer. You can do your exercise stress test inside the scanner, and you can potentially assess the exercise cardiac reserve or your athletes. And this is going to be my last slide. And I chose this one from this position paper published in January in 2017 because I think that summarized really well which is the common feeling toward the technique, okay? So everyone recognized that CMR is able to identify pathology when the ECG and the echocardiography appear normal. So as an added value, okay? And it's very comprehensive because I show you that can be used essentially in every diseases, and it's giving you a lot of information, and it's giving you a lot of information in one single test. You can combine morphology, function, tissue characterization, valve, coronary anomaly origin, so you can answer to whatever you want. The problem is that it costs a lot of money, and there is a limited availability, so it cannot be used as a screening test because a lot of people doesn't have access to this test. There is another problem, and this is responsibility of centers that are doing research in this field, that is there is a high burden of false positive. Like, for example, there is the tendency to over-reporting trabeculation, right ventricle dilatation, all these minor late gadolinium enhancement, and sometimes create a lot of problem in the management because we don't know the clinical significance, especially when you have an asymptomatic patient. But we need to work on this. And thank you very much for your attention.